All right. Welcome everyone to the first RJOS Subspecialty Spotlight. We are very happy to have you here with us tonight, and I'm excited that our first Subspecialty Spotlight is on hand. We'll be having a series of these, with the next one being on pediatric orthopedics in July. And I'm thrilled to have a really phenomenal faculty tonight. And so I don't want to take away from all the outstanding education. So I'm going to introduce our faculty, and then I'll turn it over to the speakers, and we'll take questions at the end. So not after each talk, but after all 5 speakers. We're very privileged to have with us tonight Dr. Tamara Rosenthal, who is Professor of Orthopedic Surgery and Chief of Hand and Upper Extremity Surgery at Harvard School of Medicine and the Beth Israel Deaconess Medical Center. She is also Vice President of the American Society for Surgery of the Hand, and her research, amongst many things, has sought to improve care for patients with upper extremity pathology, with a focus on fragility, fractures of the distal radius, and she'll be talking about that tonight. And we have Dr. Lauren Wessel, who is an assistant professor of orthopedic surgery at UCLA. And Dr. Wessel is not only trained in hand surgery, but also in orthopedic oncology. And her research focuses on upper extremity tumors, as well as carpal instability. And she'll be talking tonight about scapholunate instability. We also have Dr. Lauren Shapiro, who is assistant professor of orthopedic surgery at UCSF. And her research focuses on patient-reported outcomes and building capacity for global surgical outreach. And she'll speak tonight about building capacity for global outreach. We also have Dr. Veronica Diaz, who is owner and founder of Palm Beach Hand to Shoulder. And she took over this practice from Dr. Charlie Eaton, who was the first American surgeon to do percutaneous needle release for Dupuytrens. And she's going to talk about percutaneous needle aponeurotomy. And then we have Dr. Jennifer Wolf, who is professor of orthopedic surgery and rehabilitative medicine at the University of Chicago. She is also the current president of the American Society for Surgery of the Hand and a past president of the Ruth Jackson Orthopedic Society. Dr. Wolf's research is distinguished in many areas, but has also included treatment and research into arthritis of the base of the thumb, and she'll be talking about that with us tonight. So thank you all very much. I'm very excited for this session and looking forward to hearing from you all and learning a lot. And I will turn over to Dr. Rosenthal.
Thank you, Dawn. So I'm going to start off with a little bit of a nerdy and dry talk on how I got interested in the topic of wrist fractures and fragility fractures. And the way I kind of went about this talk is mostly just to talk about the journey of how I got there, as opposed to a lot of time on the actual results as what's been found. I started this, can't advance it. Hold on. It's not liking me. One sec. Try that again. There we go. So I started getting interested in this when I was a resident because just covering the ED for consults, there were so many distal radius fractures that we were getting called to see. So approximately 2% of all the emergency department visits are for wrist upper extremity fractures. And we typically would see this in bimodal age distribution in young people and in older patients. I think female patients tend to have this more often. We would see it more in the winter. And what I was curious about, or became curious about, is what effect that had on patients longer term in terms of what their morbidity was. Because at the time, we spent a lot of time talking about hip fractures and how that increased morbidity and mortality in patients. And I was curious whether wrist fractures had a similar effect or not. So that's kind of how I began. My first project I ever worked on was as a resident, looking at a cohort of patients in the Philly area because I was a Penn, and looking at all the ones who had distal radius fractures and comparing them to other patients who were age matched. And what I found in following them over a 7-year period is that the patients who had distal radius fractures actually had worse survival. It was about 57% versus 71% over that time period. And then if you looked at, obviously, if they had more comorbidities and were sicker, their mortality was worse, which you would expect. So that was the first sort of data point that, well, maybe, distal radius fractures might be kind of interesting, and they seem to be associated with an increase in mortality, but the reasons for it were really not clear. So was it the fracture itself that was causing the problem, or was the fracture just a marker of something that was going to happen later? And that's kind of where I got interested on the osteoporosis track, because we know that hip fractures have an increase in mortality. And we also know that if you have a wrist fracture, your risk for hip fracture is 50% higher. So maybe wrist fractures are just kind of the first thing that you could pay attention to. And if we screen those patients correctly, you could decrease the morbidity and mortality that comes later. And there's really good data both on the ortho side as well as on rheumatology literature that we do not do a good job of this, and that only about 30% of patients who have fragility fractures actually get screened for osteoporosis afterwards. So then I finished residency, I finished fellowship, I started my new job at the BI, which treats a generally fairly geriatric patient population. And I wanted to see how, just as a baseline, how we were doing as a hospital and as a system in terms of managing this problem. So again, collected a cohort of a bunch of patients with distal radius fractures who were over the age of 50, and retrospectively looked at their charts and found that after they broke the wrist, most of them didn't get any type of screening, like a bone density or anything like that. And about 70+% didn't get any type of treatment, like not even a calcium vitamin D pill, nothing at all. And the other interesting fact was that if they did get a bone density, their treatment rates were a whole lot better. So it seems that if you have that result in hand, hopefully you can drive the treatment better. And then among those who had bone densities, most of them fall in the osteopenia category. There's a few that have osteoporosis, but most of them are kind of one step short of that. So, okay, what do we do with this? So the next step for me, having looked at all the literature of what's been done, and there's been lots of different things tried, was to design like a 2-phase randomized trial where in one group, we just asked the PCPs to manage their osteoporosis. And in the other group, we kind of took ownership and did it ourselves. And so we just started ordering bone densities when we treated their fractures. And when we looked at the outcome 6 months later, what we found is that if we actually took some ownership and did it ourselves, our treatment and screening rates got a lot better. So instead of 30%, we're now in the 80s and 90s. So it seems that something fairly simple, which is just taking some ownership of the problem, can help drive the treatment. We talked a lot about this in women. We know a little bit less about osteoporosis in men. I think it gets mischaracterized as a women's disease, even though actually fragility fractures are going up faster in men. And when we parsed out the men in this cohort and looked at them, we found that the experience for them is even worse. So almost 10 times less likely to being screened, 16 times less likely to get treated. And they're just as high risk as women if you run this FRAX algorithm, which basically establishes what their clinical risk factor is based on their history. So the next question that comes from there is, well, okay, so we know that these patients need to get screened, and we know that they need some treatment, and what is the right treatment, and what should we do with this? And bisphosphonates are still today the first line of treatment for osteoporosis, but there's a lot of controversy about them because they have delayed fracture healing in some studies. In some studies, they actually accelerate it. And so it wasn't clear whether it was safe to do this. In the hip fracture the literature, a lot of people like to wait on starting bisphosphonates until after the fracture is healed. So this, I took that same cohort and just divided it into those who were on bisphosphonates when they got injured and those who were not. And we followed their x-rays over a while to see how they healed. And in fact, what we found is that they more or less healed the same. The ones on bisphosphonate, it took a little bit longer, about a week longer, but nothing really clinically significant. And obviously, as you would imagine, the more complex the fracture, the longer it took. There was another study that came out of Korea, which was a little bit of a different question. So what they did is they randomized patients after surgery, specifically after surgery, to either be treated with a bisphosphonate or not. And then they followed them. And at 6 months, they found that everybody healed and their clinical outcomes were the same. Their dash scores were all great. And so their conclusion was, you can actually start it after the fracture. And so I then went back and looked at it one more time in a more rigorous way where I x-rayed all the patients like exactly at the same timeframes. And again, found that the results were really similar in terms of all their clinical outcomes and their wrist fractures healing. So when you put all that together, this is a slide from that smaller cohort that we followed at very specific intervals, where you see that they really healed at very similar timeframes. So when you put it together, it basically shows you that if they're on bisphosphonates, it doesn't really seem to have an issue in terms of healing in this particular population. And so if you have a patient with a wrist fracture, there really should be an opportunity, if they're not on a bisphosphonate, to start them on one. And obviously, if they're on one already, to continue to follow them in terms of what comes next. So once you manage the bisphosphonate part, the next interesting question is vitamin D, because that's another thing that's gotten a lot of attention in the hip fracture literature. And in that patient population, we know that low vitamin D is a risk factor for fracture. But in the wrist fractures, it really hadn't been looked at a lot. There was one study in Norway that had looked at it. So on this particular project, Dr. Wolf and I teamed up and we did a 2-center study between UConn, where she was at the time, and our group. And we we collected patients prospectively who had a fracture, and we looked at controls. And we compared what their densities were, and then we compared their vitamin D levels. And we also looked at a whole bunch of other markers of bone formation and bone resorption, trying to see if we could figure out what the best marker is to determine who's at risk for fracture. And what we found is actually vitamin D didn't really make a difference. So if you look at the bar graph on the left, no matter how low the vitamin D was, the risk for fracture did not really go up. But this other marker, P1NP, which is a marker of bone formation, actually the odds of the higher that was, the higher the odds of fracture were. And if you combine it with bone density, like on the curve on the right, if you look at the dashed line, which is low bone density, as well as high PINP, if you get to the top right of the screen, your probability for fracture is 80% or so. So like maybe that's a useful marker that we could use. Maybe that's what we should be measuring in patients to figure out who might get a fracture. So from there, these are all postmenopausal patients, and it's great to figure out who after menopause is going to be a risk, but it's much more interesting to figure out earlier on if you can pick it up in a young person. So did another study that the American Foundation for Surgery of the Hand was nice enough to fund, and we then took premenopausal patients with fractures and actually measured all their turnover markers over a whole year at defined intervals. And we looked at fractures and non-fractures and compared them to see if there was any difference. And here we identified a couple of new markers that haven't really been looked at in as much detail, including sclerostin and DKK1, which are different parts of the bone formation pathway. And we found that the greater the fracture severity, the greater the increase in these markers. And so if you look at these curves, which are kind of busy, but if you look on the bottom two on the right-hand side, you can see that all the other markers kind of come back to baseline over time. But those two, the DKK1 and sclerostin, stay different. So that leads us to think that maybe those are the most helpful ones. And maybe in a younger patient population, perhaps we could be measuring this in a 20 or 30-year-old and figuring out whether their risk for fracture is higher, and then potentially figuring out what the right interventions are. From there, spent a little bit of time on imaging, because DEXA scans are the gold standard, but they don't always work. There's lots of patients who have normal DEXAs who also break their bones. And there's been some work done on MRI, ultrasound, and CT. So I started off with CT, which gives you these micro CTs. It gives you a real assessment of the bone architecture. So it'll tell you how thick the trabecula of the bone are and how separated they are from each other. And it's a different way of looking at bone fragility. And this, again, we did in younger patients, because that's now my interest, is to try and figure out if we can identify the young people at risk. And what we found is if we scanned people who had fractures and we scanned their other wrist or their distal tibia, and we compared them to controls, all of the bony architecture parameters were different. Some were in the order of like 6 to 14%. And that remained even after we adjusted for age and after we adjusted for bone density. So clearly there's something different in patients who are young who have fractures, and their architecture is different. And again, this tool, it's research right now, but it's getting more and more used in Europe, and perhaps it would be useful as a screening thing. This is a newer technique that's called reference point indentation, and this is the first tool that allows us to measure. So you have bone density, which tells you how much bone you have the architecture, which tells you how it's built, and then this tool allows you to figure out how strong the bone is. So what it does is you have a little probe and you numb up the anterior part of the tibia, and this little probe is like a 25 gauge needle. It's very small. It creates a microfracture in the bone, and it has a standard measurement that it provides that's called the bone material strength, and it'll tell you what the ability of the bone to resist that stress is. And we recruited a whole group of patients with wrist fractures and hip fractures and controls and did this on them. And the groups were basically similar, except for that the fracture patients were older and had lower bone density, which you would expect. And what we found is that this BMSI measurement was lower in the patients with distal radius fractures, even when we controlled for all the other stuff like age and body mass index and their bone density. And so this appears to measure a different element of skeletal fragility. And it may not be super useful on its own, but combined with BMD, it might be. So in the patients who have normal BMD, this might be another indicator that you can use to figure out why their bone is different or abnormal. So to conclude, how do I put all this together in my day-to-day practice? Basically, any postmenopausal woman or a man who's over 60 who comes with a distal radius fracture, I will order a bone density test. If they're on bisphosphonates, I leave them on it. I'll start calcium and vitamin D when it's appropriate. If they have not been treated and should, I will write that first prescription for alendronate, which is typically the first generic bisphosphonate. And then I will communicate very closely with their PCPs to tell them that I'm doing that and to have them follow it and continue to do that, because that's not something that I necessarily want to do. On the younger patients, I give them a warning sign that they're at higher risk. We don't have a great treatment for them yet, but I talk to them about just lifestyle interventions to prevent future bone loss. And then who do I refer? Anybody who's already been on treatment, who's failed, anybody who has a known metabolic abnormality, and then people who have multiple fractures, I think are good referrals for endocrinology. And that's my super quick summary. Thank you.
All right, that was amazing and a tough act to follow. First, thank you to RJOS for putting this on. Excited to be part of this group. I'm Lauren Wessel, and I'll be talking about new insights into ligament anatomy of the wrist and how this applies to scapholunate dissociation. I don't have any disclosures. And we'll start with a quick case. So this is a 34-year-old right-hand dominant laborer with a 2-year history of wrist pain who denies any prior injury, but complains of pain over his dorsoradial wrist, tenderness to palpation and swelling, and has a positive Watson. As many of you would do, our next step was to get a bilateral AP clenched fist view, and you can see the scapholunate widening. And so, we get here as hand surgeons, and really the next question is, what next? What more is there to this problem? There are a couple of other radiographic parameters we can look at. On plain films, we can look at SL gap, normal being less than 3 millimeters. Our radiolunate angle tells us about DZ, and aberrations in our scapholunate angle also give us information with regard to rotational stability. And then more newly introduced but important parameter, dorsal scaphoid translation, tells us about the proximal pull of the scaphoid and where it sits in relation to the scaphoid tubercle on the radius, and not passing this dorsal tangential line in green. This has been most closely correlated to pain after treatment for this injury. And really, scapholunate instability is the most common type of wrist instability. It's associated with dorsal-radial wrist pain and swelling, and it was first recognized by Destot in 1926 and later operationalized by Linscheid and Dobbins in 1972, but has really confounded us for a long time as surgeons, and we don't really have a good consensus on the workup, classification, or treatment of this problem. And so what are we learning now, which is different from before? I think if we look generally at the scapholunate ligament itself, we know a lot about this ligament proper. The dorsal aspect is the thickest and strongest with transversely oriented collagen fibers, and is the primary restraint not only to distraction, but torsional and translational moments. Whereas the palmar and proximal or membranous portions are both considerably thinner. The palmar portion contributes primarily to rotational stability, whereas the proximal portion contributes little to no restraint to motion in isolation. But really, when we think about the advances in the field in the past, I'd say decade or so, there's been a real focus on the critical wrist ligaments, or what were previously referred to as the secondary stabilizers. So since 2018, a quick Google Scholar search will result 11,500 new publications on this topic. And really the considerations are, what are the impacts of these ligaments with regard to stability of the wrist? And then how does this inform both our approaches and our reconstructions to the wrist in the setting of scapholunate dissociation? And for those of you in the audience who are new to this area, I know there's a span of students to practicing surgeons on. We're really talking from the dorsal aspect of the wrist about the dorso-radiocarpal ligament, the dorsal intercarpal ligament, dorsoscaphotriquetral ligament, and then in some cases, the dorsal capsuloscapholunate septum. And you can see over kind of 1999 to 2008, there was a progression of different anatomic descriptions of these ligaments with variable reporting of both the presence of certain ligaments as well as where their insertions and origins arose from. And really what we're coming to is, how do these kind of variable descriptions of the origin and insertion sites of the ligaments impact how we treat the problem of carpal instability? And so when we look at our classic ligament splitting approach to the wrist, or fiber splitting capsulotomy, however you want to refer to it, there is violation of the lunate insertion, which is reported in various of those prior anatomic works. And so understanding these a bit better will inform us as we go forward for our treatment of these injuries. So in 2019, Alfonso Perez studied 30 fresh frozen cadaveric arms and did a serial sectioning study. And in this study, he came to find that it was not just with SLIL, or scapholunate interosseous ligament division, that we would develop or cause carpal instability, but there had to be a combination of at least 2 other ligaments. The STT ligament on the volar aspect of the wrist, but also the dorsal endocarpal ligament, either from its lunate or scaphoid insertion, had to also be violated. And so we expanded his work to get kind of more clarity from the discrepancies from our prior knowledge from the literature of where are, but in looking at the DRC, we found a consistent in 100% of specimens insertion of the DRC on the bare area of the lunate, which was previously thought to be devoid of any ligamentous insertions. Additionally, when we looked at the DIC and DST, which are the intrinsic carpal ligaments, the DIC represented a superficial structure which spanned from the trapezium and trapezoid over to the triquetrum, whereas the deep DST spanned from the triquetrum over to the scaphoid across the waist. And so you can see in peeling back these fibers meticulously that the DST was actually almost like a labrum-like construct for the capitate, preventing palmodorsal translation. And we confirmed these findings on histologic analysis, noting the areolar tissue between the two ligaments, and also in some polarized light microscopy confirmed these findings as well. We expanded this to MRI confirmation and found on kind of high quality research study type MRIs that we could delineate the deep from superficial fibers of the DST and DIC, and also show that on the axial, we had that kind of labrum-like structure, which was a restraint to dorsopalmar translation of the capitate. We reconstructed this using three-dimensional modeling of the structures. You can see the DRC in green, the DST is in orange beneath, and then the DIC spanning, again, the triquetrum all the way over to the trapezium and trapezoid in red, and modeled this using kind of CAD imaging. And with these anatomical, or with this kind of expanded anatomic understanding, wanting to understand how those updated insertion and origin kind of points would then inform our approach to the wrist. So we performed then a biomechanical study with SL intact and divided states, and then also after performing a dorsal ligament splitting approach to the wrist, or FSC, versus what we then termed a windowed approach to the wrist, where we spared those lunate insertions of the DIC and DRC, and then further expanded our study to look at a state in which the arthrotomy was closed using either a classic repair with a baseball stitch or suture anchor repairs to reconstruct the lunate insertions of the DIC and DRC. We studied those radiographic parameters, which I mentioned before, including SL gap, the radiolunate angle, and the scapholunate angle, as well as dorsal translation of the scaphoid. And we modeled kind of all of these out in a number of graphs, which we'll go through. In each of these graphs, the intact SL is in the first state, SL division is in the second state. The state of the wrist after approach is in the third, and then closure is the fourth time point. And each of these quadrants represent the different radiographic parameters. The black line represents the dorsal ligament splitting approach or fiber splitting capsulotomy, and there was a significant alteration in all radiographic parameters when compared to the intact and SLIL divided conditions in that fiber splitting capsulotomy approach. However, after performing a windowed approach to the wrist, there were no significant changes in any radiographic parameter, indicating that the window approach does not perturb the SL or dorsal wrist stability. And then following closure with a suture anchor in the fiber splitting capsulotomy group, all of the radiographic parameters improved with no improvement compared to the standard closure. And this is important because in the cases in which you do need to have a broader exposure to the wrist, this is to say that the dorsal ligament splitting approach can be used, but care should be taken to close this appropriately. And so we expanded this to conclude that the fiber splitting capsulotomy or dorsal ligament splitting approach to the wrist may create iatrogenic changes in carpal posture that may not be fully corrected with a standard or anchored closure, and that the windowed approach does not cause aberrations in carpal posture and may be considered when access is appropriate. And you can see a diagram that we kind of outlined of that windowed approach. So really taking this in kind of a broader light, what are these bigger advances about how we think about scapholunate instability and in general carpal instability now in 2023 versus back when Villegas and Garcia Elias were initially trying to grapple with this issue in the early 2000s. And so now we really think about these secondary stabilizers rather as critical ligaments, and the analogy being like boats on a mooring with the bow and stern held by kind of these counter forces. And any aberration to the volar dorsal ligaments from either side could cause an imbalance in the kinematics and then lead to progressive wrist dysfunction. So important to consider these all when you're thinking about a patient who comes in with that AP bilateral clench view with scapholunate dissociation and widening. It's not really just about the scapholunate interosseous ligament. So back to this case, which we just referred to, we have our 34-year-old patient who has widening of his SL interval on AP clench fist view. And this is really an example of dynamic instability. Again, there are tons of controversies about how to classify these patients and what the appropriate next steps for treatment is. But what we can kind of, in general, amongst all of these classifications, agree upon is that this is the early stages. There is no rotatory changes or fixed deformity for this patient's wrist. So in this case, you can get an MRI, you can then next proceed with arthroscopy. There are a million other kind of decisions in the workup for this patient, but you have to suspect that there is another ligament which is perturbed rather than just the scapholunate interosseous ligament. And so this patient proceeded with a wrist arthroscopy. You can see here with the depicted arrow that this included the avulsion of this capsular or kind of extrinsic and intrinsic ligament connection to the bare area of the lunate. And these types of injuries can be treated with a radical procedure, which is a relatively newly introduced procedure in which we introduced a suture anchor to the bare area of the lunate. We then thread this through the DRC and the DIC attachments, and then retract the extensor tendons and tack this down. This patient has had good results at 6 months out, and this is a credit to Dr. Williams and Dr. Wolf who put this case together. In conclusion, SL instability, we know in 2023 is not just about the scapholunate interosseous ligament. The DRC, DIC, and then on the volar side, long radiolunate and STT ligaments play a critical role in the stabilization of the carpus in the setting of an incompetent scapholunate interosseous ligament. And we really should start thinking about ligament-specific approaches to the wrist in the treatment of SL instability. Not everyone gets an internal brace, not everyone gets an anafab, and not everyone gets a radical. We really need to think about how these ligaments kind of interact with one another. And then further, the windowed approach to the wrist spares violation of the dorsal wrist ligament insertions on the lunate and provides safer access to the wrist. Thank you to RJOS, and thank you to my team who helped put this research together.
Can everyone see that okay? Excellent. Okay. So good evening, and thanks to RJOS and ASSH again for hosting us. We're going to get a little less technical with this talk, but we'll review some of the work our group has been doing related to global surgical capacity building. So I wanted to start off with a case and ask some questions that we'll go through during this talk. This was a slightly unusual situation where the clinic we were going to knew that we were visiting and had a microsurgeon there with some microvascular experience. But briefly, this is a 35-year-old female with a history of wrist pain with a biopsy diagnosis of giant cell tumor. We were able to remove the tumor, which had unfortunately invaded the carpus. We then harvested and placed a free vascularized fibula graft. Here is with the tumor out. We've plated across the free fibular graft with the instruments that we have and attempted an RSL fusion given the involvement of the joint. I wanted to ask some questions to dive into the meat of this talk and to get you thinking. So you round on this patient, you see her a couple more times before you leave this trip. She's doing well, but I think some questions to ask yourself. Did this surgery help this patient? And if so, how do you know? Who, if anybody, followed up with this patient? How did the operation impact the lives of the community in which this patient lives? And was she able to return to work? And did you leave the patient in the community with a complication the local surgeon perhaps wasn't able to deal with? So these are all things we think about and can typically answer in the US, but I think things are a little bit murkier when operating on outreach trips abroad. So here's a brief agenda of where we'll go, and the highlights we'll hit with the about 10 minutes that we have today. So the field of global health has grown immensely with remarkable progress that's been made. While once considered a field focused on infectious disease, the scope of global health has expanded. To put things into perspective, trauma kills more people than HIV, AIDS, malaria, and tuberculosis combined. This burden disproportionately affects those in low and middle income countries, as well as the young, who constitute the backbone of any country's workforce. For each death, there's many more individuals that live with trauma-related disability, contributing to this vicious cycle of associated healthcare costs and decreased productivity. These are some big picture stats that help quantify this burden. So research has shown that approximately 5 billion patients or people don't have access to necessary, safe, and affordable surgical and anesthetic care. And an additional 134 million patients or surgical procedures are needed in low and middle income countries annually to prevent disability and save lives. From a monetary perspective, almost $8 trillion of GDP will be lost worldwide over the next 15 years from decreased economic productivity due to injury, with losses almost 50% greater in low and middle income countries than in high income countries. Recognizing this, it's easy to understand why addressing worldwide disparities in injury burden and access to high quality care is essential for achieving health equity. So with the increased interest in outreach to low and middle income countries is great. These endeavors can be improved with parallel efforts to ensure the delivery of safe and high quality care. Over 6,000 medical trips costing about $250,000 annually are sponsored from the United States. It is critical that these trips are conducted safely. To put things into perspective, imagine you work your normal week, operating, clinic, et cetera, and the next week you fly down to Tanzania with health volunteers overseas. You don't speak the language, you've never been to Africa before, you get tossed into a case like this. You don't know if the consent has been done, what kind of discussion has been had with this patient. You don't know who's going to follow this patient up post-operatively, if they can deal with the complications, or if you even have the correct instruments. This example, or at least parts of it, are not uncommon when operating in low and middle income countries. So the vision here is that ensuring quality is just as important as ensuring access, and that every patient has access to sustainable and high quality surgical care. And that brings us to capacity building, which is defined as a partnership approach towards developing and strengthening local communities through education and empowerment. These are just a few things we do in developed countries to ensure safe and high quality care. Not adhering to these in the United States could risk harm to patients. Not surprisingly, many of these things are difficult, even in settings with abundant resources. And many are notably absent or infrequently done on trips to low and middle income countries for a variety of reasons. And notably, none of this work is done in isolation. This is a group of 10 hand and upper extremity surgeons with experience in global surgery, all with the vision of ensuring that hand surgery outreach in low and middle income countries is the same quality as that in high income countries. So all resources that we've developed as a team that aim to build capacity in low and middle income countries. I'll touch on the results of each project as opposed to the methods in development, given the time constraints that we have. So I don't think anyone listening here today would show up to a case and not know what the case was, what implants were available, whether or not you had fluoroscopy or a microscope in the room. We developed this tool to help tackle the issue of trip preparation by creating a needs assessment tool to evaluate the needs of a site prior to an outreach trip, with the goal of improving site selection, expectation setting, and the delivery of high quality care and education. In low and middle income countries, data collection, especially via or through an electronic health record system, is uncommon and is often a barrier to quality measurement and quality improvement. Medical records are typically inadequately supported and poorly managed. They're often ineligible and require significant administrative attention and time. They often provide little utility after the patient has been discharged or even beforehand. This is an example of an electronic health record system that we've developed. We developed this as a lean and usable electronic health record system that doesn't take much time or burden to utilize. This allows us to operationalize the quality measures that we also developed to make sure that we're operating on the correct patient, the timeout is complete, and other things that we take for granted in the United States. The system allows us for image upload, implant tracking, which you can imagine are quite important for follow-up. This was piloted on a trip with Operation Rainbow in Ecuador in March of 2023. We saw over 23 patients, 25 of whom were operated on. Utilizing measures of implementation and clinical success, the electronic health record rollout was deemed successful. And notably, at 2 weeks follow-up, patients' numerical rating scores of pain were decreased substantially from their preoperative scores. And what about long-term outcomes? We know that distance and several other barriers hinder follow-up. And we also know that outcome data after trips is frequently not collected nor reported. Fortunately, cell phone and data network penetrance is high throughout the world, as demonstrated on the graph on the top left. On an outreach trip to Vietnam, we utilized a HIPAA-compliant SMS-based platform through which we could text message patients' pain and outcome surveys to see how they were doing. Our initial data was promising, with excellent rates of collection, even 3 months after trip completion. So this is a neat figure depicting how patients' quick dash scores decreased over time, indicating that they were, for the most part, improving. So back to our case from the start. Given some of these tools, we were able to evaluate the impact of the surgery for this patient. We were able to get follow-up that demonstrated her fusion sites had healed and that she was back to her activities of daily living. So this is a brief overview of some of the highlights and things that we're most proud of. But if you're interested, there are multiple different ways to get involved. Taking a trip can require some time and preparation, but there's many different organizations, including those through the Hand Society and Touching Hands, Operation Rainbow, Health Volunteers Overseas. Virtual learning after COVID is the new normal. You could help create educational videos, content. The IGOT portal through UCSF, the Institute for Global Orthopedics and Traumatology, has created several of these and is also a great resource. Mentorship, there's lots of different ways to get involved with overseas mentorship, especially with the organizations that are noted above. And then lastly, research. A lot of the academic groups have global surgical outreach research programs that you can reach out to get involved as well. So thank you.
Can everyone see my screen?
Yep.
Okay, good. Lauren, that was amazing. You need to be very proud. We're going to move on to something a little less ambitious. We go from solving the world's problems to talking about percutaneous needle release. A really focused sort of technical talk on patient selection and technique. So I'm the private practice representative of the group. My name is Veronica Diaz, and I'm by myself in South Florida. I have no financial interests to disclose. The objectives of this talk are to make a compelling evidence-based case for incorporating percutaneous needle aponeurotomy into your practice, to share some pearls on patient selection and review the technique. There's a really good technique article in the Journal of Hand Surgery by the person who taught me how to do needle release, if you want to look it up. So we know Dupuytren disease is a fibroproliferative disorder of fascia. It has strong genetic and autoimmune components. Trauma can exacerbate it, and it's in essence a dysregulation of myofibroblasts that leads to abnormal expression of type 3 collagen. This in turn leads to nodules and cords, which can lead to progressive contracture of the hand and fingers. In 2023, there is no cure for Dupuytren disease. Whatever we do to treat it is managing the disease and not eradicating it, and surgeons are not known for managing chronic disease. So just a little existential question. How and by whom should Dupuytren disease be managed? And the answer is probably not by surgeons and probably not with open surgery. The answer probably lies in immunomodulation and biologics. And that's what one of my mentors, Charlie Eaton, is doing. He formed the Dupuytren Research Group. This is an amazing resource, not just for surgeons, but for patients. I put the website on there if you want to screenshot it. And he's collecting blood samples from patients with varying degrees of Dupuytren disease to try to identify biomarkers that we can target. And if you think that this is a long shot, just consider the evolution of care for rheumatoid arthritis in the span of my career. I remember being a medical student at the University of Florida and rotating through Dr. Paul Dell's clinic. And 50% of the patients in the waiting room were patients with rheumatoid deformity. And I don't know about the other women, amazing, high achieving women on this call, but I see very little rheumatoid deformity in my practice. Why? Because the anti-TNF alpha and IL-1 and the other biologics are so good. So it's not that much of a long shot. So the history of percutaneous needle release, Sir Astley Cooper described an NA-esque technique with the equivalent of a number 11 blade. But the real inventor of the procedure is a guy named Jean-Luc Lermuseau, who's not a surgeon. He's a rheumatologist in Paris. And he used a needle and no incision. And Charlie was the first US surgeon to adopt needle release after traveling to Paris to learn the technique. And pure serendipity, I finished fellowship in 2010, and that was the year that collagenase got approved. So my fellowship director and dear mentor, Mark Barretts, made sure that the 3 fellows from that year all graduated getting certified in collagenase, and I wasn't entirely sold. We had our guest faculty for our fellowship graduation. We got to select the guest faculty, and we chose Peter Stern. And as most of you know, Peter Stern made an entire career out of publishing on his results of other people's techniques that they had reported positive results on. And he was exuberant about having gone to learn needle release from Charlie. I had taken a job 20 minutes north of where Dr. Ian practiced. And so he was very generous with me. He let me come spend a day with him to learn needle release. I had no training in residency or fellowship on it. And fast forward a few years, I left my group and I ended up buying his practice. So the benefits of NA are that it's convenient. You can do the consultation and the procedure on the same day, which is great for people who are traveling from afar. Direct costs are way more favorable than collagenase or surgery, and not to mention the indirect cost savings of time off from work and therapy, low complication rate, and patients want it. So there's a patient demand for it. I'm going to cruise through these slides because they're all from the Journal of Hand, but it's just to prove a point, and that is that there's a little bit of a disconnect between the literature and the research supporting needle release and how many people actually perform it. So in this study, comparing collagenase, open fasciectomy, and needle aponeurotomy, collagenase had the highest rate of reintervention at 2 years, a comparable reintervention rate at 5 years to NA, and much higher cumulative costs. So NA was the least expensive, and it resulted in longer duration before reintervention compared to collagenase. This is Gary Pess's paper, looking at a series of over 1,000 needle releases. The amount of correction achieved at the MCP was more than the PIP, and that was statistically significant and not surprising. MCP correction was less likely to recur than PIP contracture, and disease was more likely to recur in a younger population. This is yet another paper by Kevin Chung looking at the cost effectiveness, and of course, collagenase 1 out there. And then this is the paper that probably led to collagenase being taken off the market in Europe. So in Europe, where the government pays for most health care in most of the countries, they really scrutinized this, and they found no significant difference between treatment outcomes between collagenase and needle fasciotomy or fasciectomy at 1 year. So my outcomes, I've performed over 1,200 needle releases at Palm Beach Hand to Shoulder since 2012. My skin tear rate is somewhere around 3 to 4%. I have one known partial digital nerve injury that healed without intervention. I had one profundus injury that was treated with primary repair and healed, but the patient had really bad recurrent Dupuytren disease, unhappy patient, poor outcome. One superficial infection that resolved with a short course of Keflex, no cases of CRPS, no cases of patients losing the ability to make an active composite fist because I gave them more extension. No one had their blood thinners held. No one required a prescription pain medicine after surgery. And it's rare, but poor tolerance of the procedure leading to poor experience does happen. So in terms of getting started with needle release, patient selection is everything. Of course, I take a good health history. I want to know whether they have a family history of Dupuytren disease. Age of disease onset is important to me. Prior treatment, including time to recurrence, tells me a lot about the behavior of their Dupuytrens, because every person's Dupuytren's biology is a little bit different. Obviously, I screen for plantar fibromatosis or Peyronie disease or any medical risk factors for aggressive or recalcitrant disease. And then I get pictures. So I worked in software for 3 years, and that's the EHR system I use, and it's mobile device friendly. So I can activate the camera within the patient chart and take the pictures, and they're embedded in the visit. And then I take goniometer measurements. So be wary if you're measuring the PIP joint, be wary of the position of the MCP when you measure it, try to be consistent. So these are the pictures I take. And then in terms of assessing the cord or favorable factors for needle release, thin, ropey, prominent cords are good. When you have good overlying skin excursion, meaning you can move it over the cord, that's great. When the predominant contracture is at the MCP as opposed to the PIP, that's awesome. And if your composite contracture is less than 90 degrees, you have a winner. By contrast, the unfavorable characteristics are thick, densely nodular cords with poor overlying skin excursion, a predominant contracture at the PIP or a composite contracture of greater than 90 degrees. Of course, any hyperextension at the DIP indicating a tight ORL, that PIP joint needs more than what you can achieve with a needle. And then of course, diffuse disease. Previous surgery used to be a hard no for me in terms of contraindications, but I've definitely ventured into doing needle releases for recurrence after open surgery. So don't just consider the contracture morphology and characteristics, but also patient demeanor and expectations. Anxiety levels matter, sussing out the patient's resiliency. I know there's all these sorts of scores you can do, but most of us can walk into a room and gauge what a patient's resiliency and coping mechanism is, what their attitude toward their impairment is, whether they're catastrophic thinkers, and then their activity demands and goals. And it's super important to set expectations. So my line is recurrence is a matter of when and not if. 50% of patients will experience recurrence at 3 years. When you do something to Dupuytren disease, the line I like to say is it's kind of like poking a bear. In a lot of people, the Dupuytren disease responds by coming back more aggressively, more densely nodular. And then eventually I tell them you might exhaust this as an option. So I have some patients who exhausted it after one try, and then I have some people who are on their 8th or 9th needle release. I prepare everyone for a skin tear so that they know that I know that it might happen. And then I tell people that if they're predominant contractures at the PIP joint, they can expect 50% improvement. So I try to under promise and over deliver when it comes to needle release. The technique is predicated on cords being insensate and important structures being innervated, as well as knowledge of topographical or cutaneous anatomy of the palmar aspect of the hand, and the fact that you're using something tiny. So a 25 gauge needle has 2 advantages. It's only 0.5 millimeter in caliber. By comparison, a digital artery is anywhere between 1 and 1.4, and it's got a little sword-shaped tip that you can use like a knife. So here's a comparison for you all at the different sizes. My setup, I do this in an exam room. It's the larger exam room where I do PRP and casting. I do have the patients do a 4% HibaCleanse scrub, and then they lie down supine on the exam table. I define the sterile field with a half sheet. I put a little bump under the wrist, and then you'll need a 3 cc syringe, an 18 gauge needle to draw, a 30 gauge needle to inject, and like a couple of 25 gauge by 5/8 inch needles to work with. You want to switch those out a lot. You want to keep the needle sharp, and the short needle length is key. So if you can think back to like the basic science stress strain curves of plastic versus elastic deformation, a little bit of elastic deformation on the needle is fine, but you don't want it to bend permanently. And then a marking pen to mark your portals. And then I'm by myself, so I watch every penny. So I've stopped opening a marking pen for these. I actually mark them before they do their HibaCleanse scrub. And I wear sterile gloves and I wear loops, but I don't wear a surgical gown. So portal selection and anesthesia. You want to look for the thinnest, most prominent portion of the cord. You want to look for bunching of the skin. You want to avoid areas with pitting, blanching of the skin, or where fingerprint marks appear stretched out. All of these are signs of poor skin reserve, and you're going to end up with a skin tear. And then you want to just inject 0.25 cc per portal of lidocaine with epi, just the dermis. Start with an MCP contracture, stay midline in the pretendinous cord, don't plunge, just sweep gently and allowing a little elastic deformation of the needle, and then reposition. Try to avoid letting the needle bend permanently. And this is a really important point, because that one really bad complication I had was because I had the MCP hyperextended while I was working on a PIP joint, and that brought up the flexor tendons and diminished the interval I had between the cord I was trying to divide and the tendons, and get constant feedback from the patient. So do I have time for a quick video, or am I done? Am I out of time?
I'll be shorter. I want to see your video. Hold on.
Okay. Okay. All right. Thanks, Jen. Okay. So this is a 63-year-old right-handed. This is a 63-year-old right-handed interventional cardiologist. He has a 45-degree contracture of the left ring MCP. He notes problems with dexterity and clearance. He's unable to take time off for open surgery. And he's, of course, worried about the risks of open hand surgery, being a proceduralist. And this is why I want to like spread this, is because he traveled 350 miles to see me for this. So. Is this good?
Yes. Great.
I did all 3 portals there. I just cut it out. So I'll skip over my post-procedure instructions, but to conclude, needle release is not a panacea, but it's definitely underutilized. We're probably operating on contractures that would do well with needle release, and we're probably spending more healthcare dollars than we should on collagenase when NA delivers a less expensive solution with arguably longer lasting correction. Thanks.
Okay, everybody can see my screen? Great. I hope everybody can. Thank you to all the speakers, to Dawn for organizing this, to RJOS and to ASSH, because I love that we've co-branded this, and I've learned a lot, so this is fabulous. So I'm going to talk a little bit about thumb-based osteoarthritis, what you need to know in 2023. See if I can actually make this go forward. These are my disclosures, nothing really to do with this. So I'll talk a tiny bit about my research, but I'm going to actually give you the summary before I start. My original question and the reason I started this research was honestly that I saw a lot of more women than men coming to my office, and I couldn't really get an answer. Couldn't get an answer out of literature, couldn't get an answer out of my mentors. So I wanted to look at, in the end, epidemiology, the impact of hypermobility, hormones, and then treatment of this. I'm going to talk a bit more about treatment than anything else, but here you go. Here's the summary, although I'm going to talk a little bit about these. We have found that when you look at epidemiology, thumb-based arthritis is 4 times more common in women, and heavier work it equals a greater risk of thumb-based osteoarthritis. Actually, particularly in men, it's a linear curve in terms of that, but I'll talk about that when I get to that slide. With hypermobility, if you are generally lax, this translates to the base of the thumb. Does that have an impact? I believe it does, but we haven't quite proven that yet. In hormones, I became interested in relaxin, a hormone produced primarily in pregnancy, but actually shown to have fairly significant effects in the musculoskeletal system. So it does show some promise as a target hormone. And then I want to talk about the state of the art in 2023 with regard to treatment. And that'll probably be where I spend more than half the time on this talk. So here's a little bit of this work. So as part of my PhD, which I did in Sweden, this was one of the very first studies I did. We used the Swedish registries and looked at a physician-provided diagnosis of base of thumb arthritis, because we wanted to see what do people show up with, more than looking at x-rays or looking at incidence of asymptomatic findings on radiographs. What is the symptomatic prevalence? And so what we found actually is that it is nearly 4 times higher prevalence of base of thumb arthritis in women. There is a similar trend as you get older, that the prevalence increases. The diagnosis is rare, as one might expect, until age 40. And then we also looked in similar databases, but actually more of them in the Swedish databases. We looked at patients of working age who received a thumb-based osteoarthritis diagnosis over a 10-year period. So they had to be less than 65 years of age. We categorized their occupational loads. We went through and actually looked at all using the international standards for the classifications of occupation. We then categorized what the occupation was and what load that applied to the thumb. And so we categorize these as light, moderate, and heavy. An example of heavy obviously is like a manual laborer, a construction worker. Light was somebody who basically is an administrator, doesn't do a ton of typing. Light moderate was actually somebody who types all day, for example. The heavy group had the highest odds ratio of thumb-based OA overall, and that's with both men and women. There was a linear relationship between load and the incidence of osteoarthritis diagnosis in men, and the light to moderate group had the highest risk for a diagnosis of base of thumb arthritis in women. How about other risk factors? So there's been some other things shown, including increased BMI. Another study out of Sweden, one in which I was not involved, follows a large group of adults, over 33,000, and they had 30-year follow-up, and they showed that obesity was independently associated with thumb-based OA in men and in women, although the odds ratio is higher in men. And so this relates to the increased odds of an OA diagnosis. You might expect, but it's been shown that increased age is associated with base of thumb osteoarthritis. And then some interesting data out of the University of Utah, some pedigree studies using the Utah database have shown increased risk of going on to thumb-based surgery in 1st and 3rd degree relatives, as well as a relationship to cartilage genes, including chondroitin sulfate synthase. So some very interesting findings, and I think we're going to find more of the genetic basis of this. Okay, well, how about laxity? So I was interested in the impact of joint laxity And so one, we wanted to look at how do you measure that? Well, one way to do that is to evaluate how much laxity there is at the base of the thumb. I looked at older studies, and Eden and Littler had described a stress view. And so we described and validated this based on actually Eaton's, Matt Tomino's, and then the Framingham study had used an X-ray analysis. And so we looked to see which of these measurements made the most sense. And so the radial space over the articular width actually is reproducible. And so was able to be used as a way to measure laxity at the base of thumb on an X-ray. We then went on to look at radiographic laxity to see whether this correlated with generalized joint hypermobility, and it does. So if you are generally ligamentously lax as measured by the Beighton score, there is a relationship between that laxity and increased laxity at the base of thumb. And so published this some years ago. In terms of laxity, I also wanted to look at hormones. And as I said, I was interested in the relaxin hormone because the relaxin hormone produces laxity at the end of pregnancy. It softens the cervix. It relaxes the pelvic ligaments in order to allow women to deliver. It also has an impact on other ligaments as well as other areas of the musculoskeletal system, including bone and tendon. It has been shown to have impacts there as well. So I became interested in this. And so we basically did a very large study at 2 centers and studied 289 subjects and drew everybody's blood, tested for levels of relaxin hormone. When you look at this study, we had 42% who tested positive for relaxin. The average serum relaxin in this study is 1.84 picograms per ml. To give you some context for that, a pregnant woman's relaxin level is 200 picograms per ml. So this was rather low. Interestingly, though, the highest serum relaxin was in women 40 to 59 years, the perimenopausal woman, the woman we see getting base of thumb arthritis. There was, however, no correlation between relaxin level and number of pregnancies. There was, disappointingly, no correlation between generalized laxity as measured and serum relaxin. However, those with higher trapeziometacarpal radiographic laxity, so laxity at the base of the thumb on X-ray, had higher scores in those with detectable relaxin. So there is a relationship between serum relaxin and generalized laxity. We went on and have been able to show that trapeziometacarpal joint synovium and ligaments have relaxin receptors, and these do correlate with the degree of osteoarthritis at this joint. And this is ongoing research. We are now attempting to look at recombinant mouse research and transgenic mice because I'm pretty determined to show this relationship, but it's not a direct relationship, much to my disappointment. But that's okay. How about treatment? Because I know we're sort of toward the end. So what's the state of the art in 2023? So first, splinting. I use this every day in my practice. Looking at a network analysis of randomized controlled trials, the long opponent splint, so the forearm-based thumb spica, is the best choice for pain relief. The short opponents is optimal for function. And that makes sense, right? You can use your wrist, you can move it. David Ring and Becker, in this randomized trial that's very quoted of neoprene versus thermoplastic splints, clearly showed that patients prefer soft splints with no differences in pain relief or function when you compared soft to hard splints. And so I recommend a lot of patients go on to the softer splint because it is a much more patient preferred way of immobilizing the thumb. And that immobilization, even overnight, can really help people. How about injections? So corticosteroid injection remains the gold standard for base of thumb arthritis. However, Quinn showed a 2.2 times increased risk of infection and wound complications, requiring surgery in patients who had steroid injections within 90 days of surgery. So I do try to move this out when I treat patients with steroid injections and they decide they want surgery. I do make them wait greater than 3 months if I can. A recent randomized trial of steroid versus PRP, interestingly, showed PRP had superior visual analog scales for pain and quick dash at a year. So perhaps this is something that's coming. And then some very interesting studies out of Europe and Canada. Heather Baltzer has been very interested in this in Canada, using autologous fat injection. So you take a small amount of fat via liposuction and inject it at the base of thumb. And a recent study out of Europe with 5-year follow-up showed that the pain decreased with this from visual analog scale from 8 to 4. So not 0, but definitely cut the pain scores in half with a sustained decrease in the DASH score in 42 patients. And Dr. Balser has shown similar findings, and she has had very positive results from this. How about therapy? So there's not a lot of therapy. There's not a lot of written about for the role of therapy in base of thumb arthritis. People have talked about pinch exercises to strengthen the peritrapezial muscles, abduction exercise programs. Julie Adams and Virginia O'Brien talked about first dorsal interosseous activation to reduce the base of thumb joint and showed this radiographically. However, there does seem to be some support for this. When you look at studies looking at splint alone versus splint and therapy, there was a better response to splint and therapy with regard to pain at rest and activity in the splint and therapy group, at least with short-term follow-up. Interestingly, though, a recent randomized trial of standard therapy versus dynamic stabilization showed really no differences at 6 weeks or 6 months. That said, especially in younger patients with hypermobility and not much osteoarthritis, this is what I send them for. And I actually will print out a few of these articles so that I can tell the therapist, this is what you should be doing. This is what's been at least evidence-based and shown to help patients with this problem. Interestingly, I mean, there's some very interesting recent studies. This is a study out of Duke and University of Rochester. They looked at promise evaluations 6 weeks after conservative treatment, and they treated patients with splinting and hand therapy or 70 patients with steroid injection. And interestingly, at 6 weeks, patients really didn't respond to any of these things. So, you know, it's an interesting study, this recent study. At least the promise scores did not seem to capture much response to either of these, to these modalities, which is sort of interesting all by itself. How about surgery? So for early base of thumb arthritis, for early pain with minimal arthritic change, you can do arthroscopy. Jeff Yao has written a lot about this. You can debride synovitis, you can shrink the ligaments, you can use interposition of multiple things like allograft tendon or other things, plus or minus partial trapeziectomy. You can do dorsal ligament imbrication as written about by Ghazi Rayan, so you can reef the dorsal radial ligament, or you can do a metacarpal extension osteotomy to change the wear patterns and loading pressure. And all of these have some role, because you want to basically preserve that trapezium. So you want to keep those things. For me, this is my go-to when I basically can't solve people who have laxity but minimal arthritis and their pain. You maintain the trapezium, you reconstruct the base of thumb ligaments with a strip of the FCR, and this is very useful in the hypermobile patient with painful instability. And many of them will respond pretty nicely to this, but it's big surgery. It's like doing the base of thumb surgery, but keeping the trapezium in. How about for established base of thumb osteoarthritis? So trapeziectomy alone. This was proposed by Jervis in the early 1900s. He liked it so much he had it done on himself. Removal of trapezium, decrease the pain, remove that contact at the articular surfaces. So Roy Mills and Tim Davis both published series of the successful use of no suspension, so just hematoma distraction arthroplasty, taking out the trapezium. And Tim Davis went on and did a randomized prospective comparison of trapeziectomy versus ligament reconstruction and tendon interposition, which I'm about to talk about, versus palmaris interposition. So just putting something in there, and showed no differences in outcomes, grip, satisfaction in 174 patients at 5 to 18 years. So very compelling data to do this. Well, a lot of people have added a lot of things. The classic is ligament reconstruction and tendon interposition using half or all of the FCR to reconstruct ligaments. Others have used the FCR passed in a figure-8 fashion around the APL or the APL itself to suspend it, or the suture suspension. The picture down here on the lower right is Jeannie Del Signore's picture of this using suture to basically place a suspension or hammock between the flexor carpi radialis and the APL tendon. And short and long-term retrospective studies have all shown durable improvements in patient-rated outcomes measures for these particular procedures. And then, to be for completeness, there's implant arthroplasty. The classic is Swanson silicone implants. That metal and polyethylene is another option. There are newer ones such as pyrocarbon and trapezial shaped metallic implants, but there is a failure and revision rate of 10 to 25% across all studies. In contrast, the soft tissue procedures have about a failure rate of about 4 to 6%, depending on whose study you read. So better failure rates with the soft tissue arthroplasties as opposed to the implant, although the implant proponents say that we are preserving the length of the thumb. How about fusion? So you can fuse the trapezium to the first metacarpal. This is recommended in young laborers with bad arthritis, like post-traumatic arthritis, perhaps in younger patients. You do want to place this in a functional position. When you put all this hardware in, people can go onto non-union or prominent hardware. And Forthus and Stern showed fairly good outcomes with arthrodesis, but plate and screw fixation, 59 done with K-wires. And interestingly, they had very low non-union rates, but they did end up having hardware problems. Marco Rizzo's Mayo study showed that a higher rate went on to non-union 17 of 126 with 9 revisions, but all of these showed grip and pain improvement. So, and it's interesting, but trapeziectomy and tendon transfer are still the most commonly performed procedure. Some people have suggested that's coding and billing. Some people have suggested that's just what people are used to or what their teaching is. This very recent article is one I like to quote: Systematic Review and Meta-Analysis. When you compare LRTI and simple trapeziectomy, both really work well. Grip and tip pitch were significantly better at 1 year after LRTI. The complication rate, however, is significantly higher in LRTI versus trapeziectomy at 3 months, no difference at a year. And then pain scores, quick dash, key pinch all showed no differences. So some slight differences there. And I'll stop there because I know we're over time. I'd like to thank Mentors in Hand Surgery. I'd like to thank Dr. Laporte for organizing this, research staff, PhD supervisors, and RJOS because it's been an amazing leadership opportunity as well. So I can put up this for questions. And I'll stop sharing. If I could make this stop doing it. Great. Thank you.
And get all of these diagnoses and other areas of hand as well. I don't see questions.
Dawn, I don't know if it's me, but I'm hearing a lot of feedback.
But if anybody has questions for the panelists, can you please either, and I guess while we're waiting, I was going to ask Dr. So, hopefully you can hear me. There's a question in the chat for Dr. Diaz. Have you gotten any pushback from the hospital or surgical center for loss of revenue from the needle aponeurotomies being performed in the clinic?
So I kind of get to play by my own rules because I'm in solo private practice. So there's nobody really giving me pushback about that stuff. I have my own host of issues I deal with. I'm like literally existential threats every day, but not that one. As a matter of fact, some insurers in their infinite wisdom don't allow that procedure to be performed in the office. So they're just costing themselves more money. So we have to review the patient's benefits before and make sure that the 26040 is covered in the office. But there's really just no need to, and I take trigger fingers to the surgery center. So even though I do a lot of hand surgery under local, I'm still, my utilization at the surgery center is good, but for this, it just makes no sense. Whenever I have to take a needle release to the surgery center, it seems like much ado about nothing. So I hope that makes sense. I'm not in an employment model, so there's no one telling me I need to take the case to the center. If I understand the question correctly, I'm not exactly sure.
Thank you, Dr. Johnson.
And Dawn's audio seems to be in and out. There's a question in the chat, I think, for Lauren.
Yeah.
Is Lacey still on? Was this a question particularly about global surgery, or is this more about kind of evaluating the literature and changing your practice or technique in general based upon literature?
Dr.
Okay. Yeah, I'm happy to take this one, and maybe a couple other people can hit this one as well. I think from my perspective, obviously there's different levels of literature. You can have big systematic reviews. You can have level 1, 2, or 3, or 4 or 5 types of evidence. So I think having multiple studies that are level 1 or 2 and or systematic reviews of level 1 or 2 make me change my practice or surgical technique. I think some other people on here, and me included, if things, or don't necessarily change outcomes, but get patients back to their function or activities of daily living a little bit faster, or possibly cost less or have different risk benefit analysis. Those are the things that kind of go into my decision making about changing my practice or technique. What do other folks have to say about that one?
Yeah, I think those are all kind of important topics. And I think, as Dr. Diaz mentioned, as she introduced her topic, sometimes you're not exposed to all of the techniques in practice that are available. And so I think sometimes these conferences really open your thought process as someone who's started practice recently, seeing my partners do things differently and maybe reevaluating a little bit of what I've taken from my training and how I might then tailor my practice and how I treat patients. Conferences are super helpful in getting expert opinions and synthesizing literature because everything gets busy. And so it's helpful to have that analysis from experts.
I'm texting with Dr. Laporte because yes, I can't hear her audio much. I'll take
Yeah.
this next
Oh,
question, but I also think we ought to, yes.
Yeah,
And
I'm
Hawkins
jumping in.
question.
I'm jumping here. Sorry, this is Anna Cohen-Rosenblum. I'm a joints Neanderthal. I've been lurking. I'm the chair of the RJOS education this year, and I wanted to just thank everybody for coming and participating. We do have to wrap up, and Dr. Laporte apologizes for her audio issues, but thank you everyone for joining us. If you have more questions, please contact us at RJOS. You can get in touch with us that way, and we can pass on these questions. And I really appreciate everybody coming. And even I was interested after doing like some total hips today. I learned. I saw your little tiny little joint stuff. That was so cute. But no, thank you everybody for coming. Really insightful, really great to, honored that you all would join us. And we look forward to continuing this series of subspecialty spotlights. We want to do them every couple of months. Next will be peds ortho focused on hip preservation, adolescent hips. So you'll hear more about that in a couple of months as it approaches in July. So thank you all for joining. Thank you so much on behalf of the RJOS Education Committee, and thank you to our colleagues at ASSH and all of the amazing speakers. And good night.
Thank you.
Thank you.
Good night. Thank you all. So sorry about my connection.
We can hear you now.
You're all the
Bye.
best. Thank you.